Good evening, everybody, and welcome to the fifth presentation of the Royal Brisbane and Women's Hospital History Series organised by the Royal Alumni. It's great to see such a great crowd tonight. Thank you very much for taking the time to come on this cold, wintry evening, but I'm sure we'll have a very entertaining night tonight. I'd like to acknowledge the traditional Aboriginal owners past and present of the area where we are meeting tonight. And I'd also like to acknowledge a few special members in the audience. Everyone's obviously special, but we've got a few more special people as well too. There to all the Alumni Committee members, and in particular to Cliff Pollard, AM, to Mr Bruce Jones, QBank Executive Director, Sales and Marketing, to Vicky and Lauren Stable, who are representing Rob Stable here tonight, stalwarts of the Brisbane Women's Hospital, including Dr Eric Mackay, the First Professor of Obstetrics, and Mrs Gaynor Mackay, nursing staff including Joy Wilson and Jeanette Wiley, Dr Brian Hill, Dr Ivor Thomas, and Dr Thomas here? I don't think Dr Thomas is here. No, Dr Thomas isn't here, sorry. We also have multiple other members that have previously been employed at the Royal Brisbane and Women's Hospital, and I'm actually not going to mention you all because I'm sure that I'll actually leave somebody out, but I'd really like to thank you for coming out and to this evening tonight. It's really great that you've actually come along. As you can see from your program, the focus of this evening is on the Royal Women's Hospital, as this year we're celebrating the 80th anniversary of the Brisbane Women's Hospital providing holistic, evidence-based and compassionate care to the mothers, babies and families that we look after in Brisbane, Queensland, Northern New South Wales, as well as the Royal Women's Hospital contribution to research and teaching. I'd like to thank our guest speakers that we're having tonight that you can see on the program who have taken the time to prepare their presentations and present this evening. We sincerely thank you for sharing your memories and your experiences, your valuable time and also your knowledge with us. I've also been asked to point out that on the back of your program are the dates for the Alumni Hospital tours and details about upcoming alumni mentoring programs. So if you'd like to be involved in that, please let the appropriate people know. And the tours, I'm yet to go on one, but I've been told they're very good. Finally, I'd also like to thank our platinum sponsors QBank and the bronze sponsor Pert & Associates. We're grateful for your continued support of the Royal Brisbane and Women's Hospital alumni so that evenings such as this can actually continue and be hosted. Our first speaker of this evening is actually Stephen Cook. Stephen Cook's a visiting medical practitioner at the Royal Brisbane and Women's Hospital. He's a graduate of the University in Queensland and undertook his training as a Registrar in Obstetrics and Gynaecology at the Royal Women's Hospital as it was then. Stephen is an inaugural Australian Gynaecological Endoscopy Society Fellow and clinical leader in Obstetrics and Gynaecology at Uniting Healthcare Clinical School. He's a visiting medical practitioner at the Royal Brisbane. His interests are in IVF and fertility, and they overlap with his interest in minimally invasive surgery and in particular the conservative management of endometriosis. Most importantly, Stephen is father of 4 children as well too. Okay, Stephen, would you like to present your presentation? Do you need anything? You're right.
I think I'm good. Yeah. Thanks, Karen, and thanks to the Alumni Committee for the opportunity to speak tonight. I was initially asked to just speak about my time as a registrar at the Women's Hospital, which I thought would be fairly boring. So I've tried to actually take the whole history of the whole 80 years. So bear with me, it's a big ask in a half an hour, but I'm trying to look at the whole 80 years of registrar training within the hospital, particularly in obstetrics. I'll have missed some people. I apologise for that. Hopefully, certainly, I think all the people that were registrars that are in this room will probably see their name at least mentioned. But if you'll indulge me, we'll go through the past 80 years. So this is the hospital that most of us will remember training at. Again, I apologise. Some of what the talks will probably overlap a bit, and I certainly know that Alanna's got some of the same photographs as I've got because we scanned them from the same book. But that's certainly where I remember coming to work. With Ned Hanlon then out the front of the hospital. He's further up the hill now, but certainly was in the turning circle there. Certainly I can recall walking into the foyer, and at that stage taxi cabs, we used to use an FM signal, and you could occasionally hear a taxi cab going down Bowen Bridge Road announcing over the speaker system of the hospital that they were doing a pickup at the hospital. The hospital started or opened as the Brisbane Women's Hospital in 1938. And fortuitously, a patient of mine gave me this book recently, which was published in 1930. And Brian Hill certainly tells me that this was one of the textbooks that he can remember using as a student. It's also pertinent that the current ONG magazine from our college, which is on abortion, specifically mentions Alec Bourne, who's one of the authors of this book, because he was in 1938 standing in court as the test case in English law for therapeutic abortion. But I decided to just go through the book and find out what was happening in that sort of time frame. So, Chapter 5, antenatal care implies a thorough general examination of the patient as early in pregnancy as possible, and a special examination to make sure that she has the physical configurations necessary for normal labour. Interestingly enough, the current guidelines in the Australian government guidelines for antenatal care don't actually include any form of physical examination. It's an optional extra. Better still, vaginal examinations were generally done in the left lateral position, and gloves were only worn in the last 4 weeks of the pregnancy. Now, I personally can't remember people not using gloves for examinations, but I can certainly remember people only using one glove for examinations. Left lateral position was also the norm for delivery. Patients only were rolled over for the delivery of the placenta. And most differently, there was a whole chapter on the contracted pelvis and specifically how to manage the obstructed labour with a contracted pelvis. And a direct quote from the book, "In general, perforation is the method of delivery which appeals to us. The child is already affected by the pressure and the risk to the mother is infinitely less." And though personally I've had no involvement with such procedures, I can still remember there was a set of perforating forceps in the labour ward on the top shelf, as I recall. Induction of labour. Again, many of you may recall oil bath enema inductions. The best part, obviously, is that you could give the castor oil floating in lemon juice, coffee or brandy. Not sure it does that. After that, a hot bath at specifically 108 degrees Fahrenheit, followed by a soap enema, high, hot and hell of a lot. And then at 4-hourly intervals, quinine sulfate and pituitary extract as an intramuscular injection. And again, there's a whole section at the end on specifically on destructive procedures with a quoted mortality rate for caesarean section of just under 2%. So very different times. So the registrars then, initially, obviously the war broke out straight after the hospital was built, and so there was really no specific registrars at the time. Professor Shedden-Adam and 2 RMOs ran the hospital till about 1945. Then in 1946, Dr. Roger Salter and Lionel Sapsford, who both were returned servicemen, they were selected to do ONG training, and basically after 1 year of training went to England, did their exams and then came back as consultants. So you'll see how the training evolves from this point onwards. Again, the term teaching registrars, it was a little hard for me to put this all together, but I think if I get it correct, the teaching registrars were in fact employed by the university to teach medical students, and Dr. James Clements was recorded as the first teaching registrar in the hospital in 1949. Dr. Keith Coburn, unfortunately I tried to speak to Dr. Coburn, he's still alive, he's probably the oldest living registrar to have trained in the hospital, he's still alive at 96. Dr. Brian Hill tells me probably he's the second eldest. And in all honesty, we'd just like to thank Brian for a lot of information that I have gleaned here. A lot of it's come from picking his brains, and he'd send me emails with names that he's remembered and where they fit into the context. Dr. John Burns, certainly I can remember him attending our lunchtime meetings. Dr. Ken Wilson was initially senior medical officer, then went to the UK, sat his exams, and came back as superintendent in 1956 or 57. Sid Page, David Thatcher, again, names that many of us will know of, but didn't actually know personally. Sid Page is still quoted by people as probably doing the fastest caesarean section around. Dr. Drake, I can certainly remember Dr. Drake telling me that when he was appointed to be a registrar, there were 3 registrar positions going, and the superintendent just said to the 3 men involved, which one do you want to do? And he said, and I always made the mistake, I could have picked I's or ENT, and I picked O&G. And up until this point, basically there were 3 training registrars and a first assistant, and at each second year there'd be 2 appointed one year and 1 the next. And we'll see how that evolves into the training positions that we have today. Just to go through the next few years, Ted Esler was in fact the first registrar to do gynaecology at PA, and at this stage people would cross between the river and do some of the obstetrics at the women's and work at PA. Certainly that was still continuing into my time. Peter Foote, Ian Kerry in the late 50s, Brian Hill 59. In 1960, Dr. Neil Jackson and Dr. Eva Popper. Lovely to see Dr. Popper here tonight. And Dr. Popper, as most of us would know, obviously was the first fully trained female consultant in the state. I can certainly remember her telling me that she was told initially that she couldn't do obstetrics because she wouldn't be strong enough to do a forceps delivery, and that was the main obstruction to her becoming a registrar. But then I think Robin Charlton went on leave, or Roger Salter went on leave, and she got appointed into a temporary position. And then one of the boy registrars had a failed forceps, which was unheard of, and had to ring the consultant to do a caesarean section, and she snipped into the room and delivered the baby. And after that she'd done that, they couldn't actually argue that she couldn't continue training. Dr. John Campbell, who was obviously superintendent of the hospital, was a registrar in 61, and he worked in all 3 hospitals, the Royal, the PA and here. Names, I'll have forgotten people, I apologise if I have, but names you'll obviously remember. And then Morris Webb, Bob Herndon, David Salt and Noel Castles. Professor Khoo comes in at about 1970, though he said he did actually start in 69, and he also told me that Bob Herndon was a little bit before that time, so I apologise if the chronology is slightly out. So what was happening in that time frame? Obviously it was the baby boom, it was the post-war period. If you ring the hospital today, it says we're delivering 5,000 babies a year. Well, in 1960 they were delivering 12,000 babies a year, and that's when it really hit its peak. The hospital originally had 160 beds, which increased to just under 300, but there was a complaint in the paper in 1957 that there were actually 400 women in the hospital one weekend. And at that time, women would be sent by ambulance to other hospitals because there just weren't bed facilities to keep them. In 1948, there were 3 lay wards. There was one on the 4th floor just for primary gravida patients. The public labour ward was in M4 then, and the original labour ward on the ground floor was for private deliveries. There was a visiting physician appointed in 53, a paediatric registrar finally appointed in 1960. And then in about 1961, 2 things happened. One was the pill and the second was the martyr, and not necessarily connected. But then there was a decrease in the birth rate within the hospital as a result of this. So the numbers did decline after that point. An anaesthetic registrar was appointed in 1961, and then through the rest of the 60s there was the cytology clinic, the smear clinic. Dr. Brian Hill tells me that the only thing he did behind Ken Wilson's back was introduce Sindometron to the hospital. As acting superintendent, when Ken went on leave, he introduced Sindometron for the management of the 3rd stage. Up until then, ergot had specifically been used. Professor Mackay came as the first professor of obstetrics and gynaecology in 1964, and certainly many of us would have been taught by him. I'm slightly nervous standing up talking in front of him because I can remember doing labour ward rounds as a medical student, and the big thing was you had to have your history backwards because the prof would certainly find out something that you hadn't asked the patient. And I can remember presenting a case to him one day, and I got as far as a 19-year-old primate, and he stopped me, and then we talked about teenage pregnancies for the next hour. And I was trying to tell him I had a lot more history than that. It says that epidural anaesthesia was introduced in 1965, but I spoke to Dr. Peter Livingston, and he tells me the first epidural was actually done by him in 1961 when he was the first registrar in obstetric anaesthesia. And he gave a single shot epidural with 1% xylocaine to a diabetic patient for Dr. Ken Wilson on a Saturday morning. He rang his consultant to see what they thought about it. They'd never done before and said, okay, on you go with it, get on with it. And it went well, and it took a few more years to introduce epidural anaesthesia after that. But by 1965, it was becoming more common for caesarean sections. Certainly GAs were still being used well into the 80s. In 1967, Dr. Ken Wilson performed the first intrauterine transfusion for rhesus disease, and again Dr. Cooper, Dr. Popper and Dr. Bobby Bevan, and then later Jim Baker were very heavily involved in the rhesus clinic, which was obviously a huge thing in the time, but certainly not even a thing we see very often anymore. Again, I spoke to Dr. Bevan in the last week, and she actually says that the pill also contributed significantly to the decrease in rhesus disease. So it wasn't just the management, medical management. Some of the names mentioned here are in this room. I hope I haven't missed anyone. Certainly lots of people have been through in this time frame. I couldn't get many photos, unfortunately. There were registrar photos taken fairly regularly. John Vesey provided me with this photo. I'm ashamed Dr. Thomas isn't here because he looks very young in that photo. But Esther is there, and Peter Fung, Deidre Bentley. I'm not sure that obviously there were lots of PHO and GP registrars as well. I couldn't try to get all those names together, so I apologise that they're not always mentioned. This photo came from Esther, which is obviously a few years later. Dr. Campbell here, again, Peter Fung and Deidre Bentley in that photo. On the front row, Ellen Mowat, Esther, Meredith Cleasy and Joanna Coburn. So the 70s and 80s, so Marcaine came in at about 1970. Big difference is that the xylocaine had significant tachyphylaxis and didn't last very long, so Marcaine gave a longer acting epidural. And so epidurals then started to be used actually for labour. Then just bolus doses, and we'll all remember times where epidurals would wear off, then they'd be topped off, and they'd wear off, and they'd be topped up, and certainly not as smooth as they are managed today. In the 70s, certainly the labour ward that I trained in, and many here will have trained in, was built in 73, 74 with the Labour Ward 1 and Labour Ward 2, and two operating theatres down one wing and the special care nursery in the fourth wing. Dr. Cooper progressed ultrasound at this time frame. Dr. Campbell, the superintendent. And in 1977, Ivor became the full-time director for the first time of obstetrics and gynaecology. The bridge connecting the two hospitals was built in 1979, and there was a link between the Royal Brisbane and then across to what was originally the nurses' quarters, which became the Lady Ramsay wing. This is the photo of the walkway, as you remember, and certainly I can recall patients, whoever you saw a patient in a bed being pushed from the women's across to the main hospital, it was usually because they'd had a sux apnea and the suxamethonium hadn't worn off, and they'd had to be taken across to intensive care to be ventilated for a period of time. Another anaesthetic story, while I remember it, again, spinal anaesthesia for caesarean sections hadn't come in. Larger spinal needles were used. There was problems with patients dropping blood pressure, and so-called spinal shock would occur, and there'd been deaths in the UK. And so most anaesthetists were very unhappy to do spinal. So the only time I ever saw a spinal done was for a failed GA. So if there were a failed intubation and they couldn't intubate the patient, they would put a spinal in to do the caesar. And I can certainly remember early one morning, Dick Drake was the consultant on. I was a fairly junior registrar, and the GP registrar who was giving the general anaesthetic had a failed intubation, and then had to bag the patient till the relaxant wore off and then do a spinal. And the patient got quite cyanosed in that process, and eventually the baby was delivered and all was well. And I can still remember Dr. Drake telling the anaesthetic registrar that they needed to be worried because though the patient got quite cyanosed, they go a horrible black colour just before they die, and they never quite got to that stage, which she, as I recall, only thought was a small consolation at the time. So certainly there's other members in the room on my list here. The late Dr. Stephen Bro's there. There's lots of stories I could tell you about Broe, and I'll tell one in a minute, but I certainly can remember if you came onto labour with Broe and there was anyone left that should have been delivered before you came on, he'd just walk out and go back and say, I won't come on until you've cleared the labour ward. So he was certainly a character. Here is a photo from that time frame. Dr. Ivor Thomas and Eric Hewitt over on the right. Again, Deidre Bentley, John Allen and Ted Weaver in the background. And Ted was certainly the sort of senior registrar when I started training. And I found this letter. I was looking through stuff that I could talk about, and I was lucky enough to have done 2 terms as a resident, my first year and my second year. And I must have finished my term here, and Ted only gave me 6. I got 6.5 out of 7. If he hadn't given me a 6, I probably would have got a 7. Anyway, this is the downstairs lecture theatre. Again, we used to do registrar lectures to the parent craft lectures, which are going on here, but the lunchtime meetings on a Monday and a Wednesday used to be held here. Again, it was an unwritten rule that if a registrar was paged out of one of these meetings, you had to page Dr. Bro to get him out of the meeting. So anyone who was pulled out was obliged to do that. I'm sure Jim Nicklin can remember that. There was an unwritten rule. 88 was the Jubilee of the hospital, and this is the year I started training. So what happened in this time frame? Video laparoscopy came in about 86. And I can certainly remember about 1989 doing laparoscopies, which up until then had always just been done by looking down the scope. And Kevin Forbes had seen this done, and the orthopaedic surgeons had a video camera for arthroscopy, which let very little light in. And I can still remember trying to do laparoscopies, and you couldn't see a thing because it was so dark, because the light source was very poor. But that was certainly the first time that the video laparoscopes started coming in. At that stage, there were 4 training registrars. There'd been 3, and then in 1988, the 4th registrar was usually a non-training year. And again, to mention Stephen Bro, he never forgave me because he'd been the non-training registrar the year before. I got the non-training position, but then I was the first person to get it accredited, so effectively level pegged with him from there on. Epidural infusions became more common. Keith Greenland, as I remember, was a registrar at the time and certainly pioneered and pushed for infusions to be used rather than boluses. And again, about this time, subspecialisation started to occur within the college, which had major implications to the training from here on in. Ectopics, up until then, you do a diagnostic laparoscopy, diagnose the ectopic, and then do a laparotomy to treat your ectopic, mini lap. Finally, in the early 90s, we could start to manage these patients surgically and do salpingostomies or salpinjectomies. Now, many of them are managed medically, so there's been, again, future changes. The gynaecology wards finally moved across to the Royal Women's as it was in about 1991, and M9 theatres were developed. Laparoscopic hysterectomy first started about this stage, and the first laparoscopic hysterectomy was done by Harry Rich in about 88, and initially most of them were done really as laparoscopically assisted vaginal hysterectomies, and then it progressed on from there. M4 closed, probably one of the major things that I remember, that one of the most efficient theatres within the hospital, and unfortunately we lost that for management of early pregnancy complications. And then the Ned Hanlon building was built about 99 and the Women's Hospital demolished in 2000. So just again, if you'll indulge me slightly, I decided to go back and look at my logbook, and like all surgeons, you always think you did more than you actually did do. But I went back and had a look at what we were doing at the time. So certainly as a first year trainee, I think I did 20 operative vaginal deliveries, including 4 Keelans, 63 Caesars and 4 abdominal hysterectomies. I'm not sure what the registrars are doing now, but maybe they're not doing any abdominal hysterectomies. So things have changed. By the end of my time training, I'd done over 40 vaginal breech deliveries, 500 caesarean sections. I'm sure people in generations before me would have done even more than this, but certainly a significant number of procedures. I'd done 6 laparoscopically assisted vaginal hysterectomies. The importance of that was up until now, they weren't being done, and I was finishing in 93, and I knew if I wanted to do them when I got into private practice, I needed to actually be sort of supervised or accredited to do it. So we used to do them with Adrian Guest on a Friday afternoon, and once I'd done 6, he was then happy to certify me to continue to do them. And again, just in comparison to medical students today, so back in 1946, medical students were expected to do 15 to 20 confinements and apply at least 1 set of forceps. The tsunami of registrars continues into the 90s. Again, more people in this room will see their names there. I've missed a couple. Certainly Ron Adam I missed in the earlier lot, and there's probably some other names I've missed here, so I do apologise. This is the old hospital. The last photos were taken, I think, from a hot air balloon to remember it. And then the new hospital opened in 2000. Initially the Ned Hanlon building, and then after the women's was demolished, the James Mann building was built. Even more registrars. So the numbers are increasing all the time. As well as these training registrars, as I said, multitudes of PHOs and GP registrars. I put this photo up, which is a more recent one, and thank Akram for this photo, but this is the tea room in the gynae theatres at obviously a Christmas celebration. Two things. You'll notice there's now no alcohol there. There had been alcohol in the hospital prior to this, and John Herming tells me that the first unsupervised Keelan's forceps he did was after one of the other registrars, who remain nameless, had just passed his membership exam and actually wasn't capable of supervising him doing a Keelan's forceps, so he had to do it unsupervised. And the other person was John Vesey, who I will name, who is still to this day teetotal, but came on Christmas Day and was quite a hot day, he said, and there was punch within the labour ward, and he'd had 6 or 7 glasses of punch because he thought it was quite nice. And then as evening came on, he felt a bit sleepy, so we went up to the registrar's room and lay down, and next thing he knew, it was 8:30 in the morning and he'd slept right through. So he was quite upset about this and complained that this punch had been spiked, and as a result there was a memorandum that no alcohol would be allowed on the campus anymore. Again, I thank Akram for this photo. The reason I've used it is it shows, 2 different registrars, Nerylene Agenda and Adrian Guest, from at least 20 years apart, still involved in workshops and training within the hospital. And so what's happened in that last sort of 18-year period? The biggest change, obviously, is Marina, and Marina has really revolutionised care. It has had a huge impact on women's health, but it's had a significant impact on registrar training as well. At least 30 to 35% of women that would have had a hysterectomy in the past no longer do because of this device. With very much less simple benign hysterectomies being done, that has a huge impact on training. So most of the fairly straightforward hysterectomies that registrars would learn to train on are almost not done anymore. So that's had a huge impact. Up until the old hospital was demolished, there were still more private deliveries than public deliveries within the hospital. And there was Labour Ward 1, Labour Ward 2, and certainly a lot of the experience I gained as a registrar was being around in Labour Ward 1. I can still remember delivering a set of twins for Alan Lee, and I delivered the first twin because he was coming from the terrace. And then he arrived and I was about to leave because the second twin was coming, and he'd got there and he said, "No, you've delivered the first baby, stay, you're going to have to deliver the second one." So he made me then deliver the second twin. So there was certainly opportunity to be taught and trained by other VMOs that had trained in the hospital who were still looking after private patients. And I'm sure others would remember examples of that. So that opportunity to be taught by other consultants and other specialists in the area has been lost a little. Carbetocin has come in. That's mainly obviously used for elective caesarean section, but it's now potentially becoming used in more frequently with the sort of routine management of the third stage. There's data coming out showing that it's as effective as other agents with less nausea and vomiting. Robotic surgery obviously has come onto the scene in that time frame, and that's changed the outlook for laparoscopic hysterectomy in many senses. Cell-free DNA and non-invasive prenatal testing. I didn't specifically mention nuchal screening, which obviously came first, but the advent of being able to detect gender and chromosomes from small fragments of free cell DNA has certainly made a huge difference in the management of the early pregnancies where there is chromosomal abnormalities. Delayed cord clamping, midwifery-led care, private midwifery within the hospital. One of the things I find slightly ironic is that certainly the number of private deliveries has decreased, and as a private consultant I can only book patients to deliver here now if they're under 32 weeks, whereas there is at least 8 or 9 private midwives with independent admitting rights. So big changes. Cell-free messenger RNA I think is probably going to be the big one for the future. Transcriptomics has become important in cell tumour detection, but also probably an early detection of risk factors in early pregnancy for preterm delivery, and I think that's an area that's going to evolve. And finally, just in concluding, we've gone from 1 or 2 registrars starting with 1 year of training to where we are today, and I apologise if I've got the numbers wrong. It was much easier to get the names of registrars from 20 years ago than it is to get registrars from today. I tried to get a list of the registrars currently training. It progressed to executive level before it was cut off. I then got a phone call from Karen, who was able to give me over the phone numbers, and then I was told that it had gone to the senior registrar, who was going to contact all the other registrars and ask their permission if we could have their names. But anyway, the numbers are probably more important than who they are as individuals, so I apologise if any are here and they aren't mentioned. But as I understand it, there are 5 advanced trainees, 6 level 1 to 4 trainees, 6 PHOs, 2 gynae-oncology fellows, 1 Urogynae fellow, a paediatric and adolescent gynae registrar, and a half-time academic registrar. Now, I wasn't sure if there was actually even any more than that, but certainly much larger numbers, obviously much different era that we work in, but certainly I guess one of the points I'm trying to make is the difference in the number of deliveries, the number of operations being done, different working hours, and obviously the number of trainees which have to then compete for that work. But that's all I've got. Thank you.
Thank you very much.
Cheers.
Thank you very much, Stephen, for that very entertaining presentation of all the history and mentioning all the things that have changed and also all the challenges that we're currently facing into the future with all the recent advances and the impacts that it has on training as well too. That was very, very entertaining and very interesting for me as well too. So great. Thank you. Okay, so our next speaker is actually Adjunct Professor Alanna Geary. So Alanna is the Executive Director of Nursing and Midwifery Services for the Royal Brisbane and Women's Hospital and also for Metro North Hospital and Health Service District. Alanna first began working at the Royal Brisbane and Women's Hospital immediately after completing her training in 1984. And in 1987 she began midwifery training at the Royal Women's Hospital, returning to the Royal Brisbane in 1988 to work in surgery, orthopaedics and also infection control. Alanna was the Nursing Director in Cancer Care Services for over 10 years before moving into her current role. Alanna is also one of our committee members for the alumni and is loyal to the Royal and has been for 34 years. And Alanna's had a few children but hasn't had her children here as well too. Okay, thank you Alanna. Now I have to push and then you've got to go to yours.
No, wrong one.
Oh, sorry. This one?
Yep. And you can start on that one. The reference to Mamma Mia is a reference to the 1980s, which I trained, and I'm happy to do a rendition of Mamma Mia if you'd like, but probably best I don't. And I don't have my outfit, so I wore that a couple of weeks ago. First of all, I'd like to pay my respects to the traditional owners of the land in which we're meeting this evening and pay my respects to elders past, present and emerging. Dr. Amanda Dines, Executive Director, Royal Brisbane and Women's Hospital, Dr. Judy Graves, Executive Director of Medical Services, Royal Brisbane and Women's Hospital, Professor Cliff Pollard, Chair of the Royal Alumni Association and Board Member for Metro North Hospital and Health Service, the Stables, Lauren and Vicky Stables here representing Dr. Rob Stable, distinguished guests, Royal Brisbane Women's Hospital colleagues, ladies and gentlemen. It gives me much pleasure to stand in front of you this evening as the Executive Director of Nursing and Midwifery Services of Australia's largest hospital and health service, of Queensland's largest hospital, and for the purpose of this evening's presentation, of the largest public birthing service in the state. I am a Royal Women's Hospital midwifery graduate, having completed my midwifery training here in 1988. I'm very proud of the time that I spent here at the Royal Women's, having worked with many wonderful nurses and midwives. Interestingly, many of today's Brisbane more senior obstetricians who were actually residents or registrars during the time that I undertook midwifery training. Time surely marches on. Dr. Stephen Cook and Dr. Jim Nicklin are two of those people. These days, women's and newborn services are much smaller in comparison and size to the Royal Women's Hospital of previous years. However, one should never underestimate the significant contribution that the previous Royal Women's Hospital and the current women's and newborn services now housed within the RBWH makes to the health and well-being to Queenslanders. When I undertook my midwifery training between 1987 and 1988, there were several public antenatal and postnatal wards, and I didn't do as well as Stephen because I actually couldn't remember all of them, and 3 private wards in the Lady Ramsay wing. There were 2 labour wards, 1 public and 1 private. There was an intensive care nursery and a special care nursery, interestingly named after our current board chair's father, Dr. Grantley Stable. There were approximately 7,500 births per year, and lengths of stay in excess of 5 days contributed to the bed stock utilisation, which Stephen alluded to earlier. Daily average utilisation of beds was around 200 in the late 80s. Interestingly, as Stephen mentioned, in 1960 there were around 13,000 births, with an average utilisation of 317 beds per day. Today there are approximately 4,000 births a year, and daily average bed utilisation is 45. However, the proud tradition of care continues even into 2018, where the largest majority of those 4,000 babies are safely delivered every year. While the numbers of babies being born at the Royal Brisbane and Women's Hospital has decreased significantly over time, changes in models of care, which include expert obstetric and midwifery attention, has meant that the bed stock requirements of yesteryear are no longer necessary. Undertaking midwifery training even in the late 1980s, which as you would all know seems like yesterday, was not without challenge. I was interviewed by the very fierce, or so I thought, Rhonda Middleton. She was pleasant, and I answered the questions to the best of my ability, but to be honest, she absolutely terrified me. Of interest, my interview was also consisted of questions like, was I married, and when did I intend to have children? I am unsure even to this day if my responses had the potential to thwart the opportunity to train at the Royal Women's Hospital. I am sure they probably could have. In those days, those of us who chose to enter midwifery usually had a few years of working as a registered nurse already under our belts. Many of us had worked in very busy medical, surgical and critical care units. We had earned our stripes, been in charge of shifts, and some of the students who entered midwifery had even been charge nurses themselves in previous lives. Well, weren't we in for a treat? Forget everything that you knew. Forget you actually already knew at least a little of what you were doing. Forget that you knew how to take a blood pressure or undertake a clinical assessment. Goodness gracious, you should probably even forget that you knew how to undertake a ward-based urinalysis. You were no longer sister, you were nurse, and for the next 12 months you were not allowed to forget it. If you could get over the fact that you were now a slightly lesser being than the rest of the nursing and midwifery world, if you could pretend that the midwives you were working with were the only ones with any knowledge, if you could be happy to not have an opinion, if you could be then you were probably going to finish your midwifery year relatively unscathed. And while that sounds dreadful, and by today's vocational standards it probably was, in actual fact it was one of the most wonderful years of my nursing career. I met and worked with some of the most amazing midwives and obstetricians, and I learnt much from outstanding neonatal nurses and paediatricians. Midwifery was actually what ignited an interest for me in infection control, and years later, when I actually became an infection control clinical nurse consultant, I drew on my experience as a student midwife to inform my practice. In the 1980s, the first of the alcoholic hand rubs came into being, and our very own Joan Webster at the time was the infection control nurse. She was working with Dr. Joan Fagali, a very impressive microbiologist who, alongside with Dr. David Cartwright, both had a hand-washing passion that was second to none. They were studying hand-washing products in the Grantley Stable neonatal nursery and were trialling a product called Hexol. It was a chlorhexidine-based product and was very, very harsh on your skin by comparison to the products that we use today. Like all conscientious and scared witless student midwives, I did exactly what I was told, which anybody who knows me now knows that doesn't come easily to me. I diligently washed my hands every time I went into a humidicrib or touched an infant. As a result of my diligence, I developed a rather uncomfortable rash on my hands. It would go away while I was away from the nursery and return the moment I came back to work. It was red, my skin was broken, and it stung like a bitch when I washed my hands. One day, I plucked up the courage to show Sister Webster my hands. She looked at my hands and said, "That is very nasty, nurse," and promptly walked away. The message was, suck it up, sunshine. Now, those of you who know and love Joan will know that she is extremely kind-hearted, wonderful nurse, midwife and friend. But far be it from me, student midwife Geary, to get in the way of what turned out to be one of the groundbreaking research studies of its time. My rash did disappear, and my skin eventually returned to normal, and I went on to wash my hands many times again, even undertaking my own hand-washing studies in the future. Interestingly, in the 1980s and early 90s, neonatal nurseries at the Royal Women's Hospital were known for their hand-washing technique. In 2018, the nursery staff still topped the pops in regular hand-washing audits. A testament of the culture instilled by Joan Webster at the time, and certainly Dr. David Cartwright, in the vigilance and care of some of our most vulnerable patients. The assessment processes for student midwives of the time were interesting to say the least. To this day, vaginal examination during labour is probably the one I remember the most, and is probably good that I do no longer work as a practising midwife. Delivering women of women's and newborn services have much to be thankful for. It was not one of my strengths, clearly. I would also like to confess that I failed milk making. In those days, while much of the milk formulas were follow the instructions on the tin, or even better, came pre-packaged in bottles, we were actually required to know how to make cow's milk into a product suitable for human infant consumption. Anne Morrison, who is now a very dear friend of mine and a former chief nurse, was the educator who was assessing me. I don't think she knew whether to laugh or cry. I failed, not once, but twice. I say thank goodness there was such a push for women to breastfeed. I was pretty good at helping mums to get babies to attach to a breast, and the milk was already ready-made. Fortunately for me, I was not all bad. I could successfully undertake all of the other assessments required of me, and eventually I passed milk making, and I'm sure if I had continued my midwifery career, which I would have loved to have done, I would have honed my vaginal examination skills. I passed my midwifery examination and duly received my certificate, much to my family's pleasure, who were concerned the whole way through my midwifery that I wasn't going to finish. They were the driving force behind me starting my midwifery in the first place, and the mantra in our house was always, if you start something, you must finish, and finish I did. As a large teaching and training hospital, and with so many health professionals to train, it was not uncommon for student midwives and medical students, residents or registrars to go head-to-head over who was going to get the delivery. Student midwives had to achieve 20 normal deliveries, and with possibly 60 or 70 student midwives every year, cohorts of med students, and you saw the registrar numbers in Stephen's presentation, we all vied for the same birthing women. We did all eventually get our numbers, and most mothers were safe, and most babies were delivered without incident. And while I don't believe there was any physical fighting in the corridors, I'm not sure about nasty looks or spoken words under somebody's breath. I have wonderful memories of midwifery training. I had many laughs. I made wonderful friends, many of whom I still have 30 years later. Some of them are in the audience today. The premature delivery of an infant, even in 2018, can be problematic. And I'm telling you nothing, my learned friends, when I say that a stillbirth is still traumatic for parents, families, and clinicians. My first delivery as a student midwife was a stillborn infant. It would have to be one of the most traumatic experiences of my 37-year health career. But the way in which the midwife who was in the room with me assisted, and the expertise of the other midwives in the management of the grief that ensued made me realise that midwives were actually angels with a tough and resilient exterior. While no one in the room that day will ever forget the experience, it was certainly made much more palatable by the compassion, care and genuine concern for mother, baby and colleagues. One of the joys of not being a health professional is the temptation to self-diagnose or think the absolute worst in any medical situation. In my early 30s, after doing my midwifery, I became pregnant with twins. As a midwife, I knew quite a bit of the complications which could occur. I had every complication going, if you ask me. And those that I did not know, I could look up. By the time I was 12 weeks pregnant, I had to give my mother my Baisha and Mackay. The reason I was convinced that every complication that could occur with a twin pregnancy would happen to me. Well, I did endure a few, including a growth-restricted twin 2 and therefore premature delivery at 32 weeks. My 2,200-gram baby and my 1,200-gram baby boy are now robust, healthy 24-year-olds. Scrolling behind me as I am speaking are the photographs of many wonderful midwives, obstetricians, health leaders, and many of the amazing memories of the Royal Women's and Hospital and now Women's and Newborn Services. These are the faces up there of some of the people in this room. People who have learned, been taught others, and continue to contribute to the fabric that makes Women's and Newborn Services what it is today. Women's and Newborn Services may be a service line in a much larger machine, but their contribution continues to be second to none. Today, Women's and Newborn Services not only looks after mothers and infants, but also provides expert care to women requiring gynaecological and gynae-oncology care. 6B North sits alongside the maternity wards and provides tertiary and quaternary services to women from all over Queensland. The nurses in this unit are expert surgical nurses with a broad range of experience who lead by example and provide care which is second to none. In the provision of expert gynaecological and gynae-oncology care, combined with maternity services, Women's and Newborn Services provides comprehensive attention to the women of Queensland, Northern New South Wales and the Pacific Rim. The 60 or so years of the Royal Women's Hospital as a standalone facility and the subsequent 20 years where they have proudly been part of the Royal Brisbane and Women's Hospital has meant that many a nurse and midwife has graced the halls and provided care to our population. Many Queensland mothers and infants have and will continue to require the attention and expertise of our wonderful clinicians. I continue to be astounded by the level of care and the professionalism that our clinicians provide. I am a proud Royal Women's Hospital graduate and now as the Executive Director of Nursing and Midwifery Services, a role which I am pleased to say excites and challenges me every single day. I am optimistic about the future and equally proud of our past. Nurses and midwives will continue to provide the exemplary care that we have for the past 80 years. Times have changed, birth rates have dropped, Models of care mean that women and babies spend less time in hospital, even for the most complex of treatment journeys. But I truly believe our care is safe, our premature babies have better outcomes, and that expert midwifery and nursing care has proved itself to be essential in ensuring positive consequences of that care. Every day I watch pregnant mothers walk into our organisation, and every day I watch happy families leave. We continue to meet the needs of our community, and I firmly believe that we will continue to do so for at least the next 80 years. I probably won't be here delivering, but I want to read you a poem, and this poem was written by a Royal Women's Hospital graduate, a dear friend of mine, Miss Ruth Horman, who trained at the Royal Brisbane Hospital in the 1960s and did her midwifery soon after. While this poem was written in her first year as a student nurse in 1961, I think it epitomises the lot of a nurse and a midwife, and while there are things in the poem that no longer exist due to the tyranny of time, the sentiment in the poem is still true today. It is called A Nurse's Day. Out of the stillness of this morn, my alarm heralds the day is born. Sleepily from my bed I creep, hurry, hurry, or time will fly, into my uniform crisp and neat, and shining shoes upon my feet. Down the hill at last I flee, just in time for a cup of tea. With beds neatly made, it's through breakfast we wade. With a clash and a clatter the dishes are done. To work in a hospital is surely fun. Sister has her charts in hand, for in comes a solemn band. Patients smile after doctor's rounds, easy to see that they are homeward bound. Others are a tearful lot, for in hospital they must stop. Block sister comes in with a frown, strange thinks she, not a nurse around. Into the linen cupboard we hop, hoping madly the door will lock. Day is done and gone the sun, good to hear the tea bell loudly rung. Up the hill at last we drag, to get out of this crumpled bag. At last by my bed I kneel, telling him just how I feel. Give me strength, thy Lord, I pray, to hold this lamp day by day. I'd like to thank Ruth for allowing me to share her work, written some 56 years ago by a clearly very nervous student nurse who went on to become a triple certificated registered nurse and had an exemplary career as a paediatric nurse. As I conclude my presentation this evening, I'd like to show you a video that was produced in 2017 to celebrate nursing and midwifery. Now I've got to figure out how to do this. In the health service. Amy, how do I do this? Can you? And then just go to, yeah. Okay. As you would anticipate, due to its size and complexity, Royal Brisbane and Women's Hospital actually takes centre stage, and Royal Women's is actually featured quite dominantly in the video. So it only goes for 3 minutes, so I'd like to show you this. Sorry, I'll just...
From the moment you start work, you know exactly where you want to be. At the forefront of clinical care, using cutting-edge technology and working alongside world-renowned experts. Part of a dynamic, supportive, multidisciplinary team, providing 3.5 million episodes of care each year. Leading a highly specialised unit, saving the lives of Queensland's tiniest patients. And saving the lives of people in our community. We're giving nurses and midwives of today and tomorrow an opportunity to train alongside internationally recognised nursing leaders at Australia's largest public health service. Providing care for some of our most vulnerable patients in their own homes. delivering 8,000 babies across Metro North each year. Giving the gift of life at Australia's premier heart and lung hospital. Being a member of a trusted emergency team, caring for kids from Brisbane's north side. It's the great team, culture and reputation that makes us proud to be nurses and midwives here every day.
Life is short. Work somewhere awesome. I apologise because the sound is actually ahead of the video and I'm not quite sure why, but I'll just let it finish. You can watch it, but it won't have any more sound. I'm so very proud of Metro North Hospital Health Service and so exceptionally proud of the RBWH. I have to be honest, in my 37-year career of nursing and midwifery, 34 years of that at the Royal Brisbane and Women's Hospital, it means very much that I'm a royal girl. The year I spent doing my midwifery was a wonderful challenge with many wonderful memories. And with my hand on my heart, I will always say, I'm loyal to the Royal.
Bracelet, you can't have that. Okay. Thank you very much, Alanna. That was once again very entertaining. It's nice to hear the perspective also from the midwifery team here at the Royal Brisbane and the journey and the changes that have occurred over the years as well too. So thank you. And very interesting video, very nice video. More people come work here. It looks nice at Redcliffe as well too, doesn't it? Nice view. Yeah. Okay, thank you very much for that. So our final speaker for tonight is Professor Soo Keat Khoo. So Soo Keat has had a 36-year working association with the Royal Women's Hospital, from his ONG Registrar years in 1969 to 1971 to its Director of Gynaecology from 1998 to 2006. During this period, he obtained a doctorate in medicine by research at the Walter and Eliza Hall Institute in Melbourne, was appointed Professor by the University of Queensland and later chosen as Head of the ONG discipline for the University of Queensland. He was also elected President of the Asia Pacific Council on Contraception and was nationally recognised by the Order of Australia as a member in 2000 for his services to medicine in Australia and the Pacific region in New Zealand. Through the Betty Byrne Henderson Women's Health Research Centre at the Royal Brisbane and Women's, he completed a 10-year study into women and ageing. Prof Khoo has had 3,093 citations for the research that he has undertaken over the years. So we're very, very privileged to have him here tonight presenting to us. So thank you very much, Prof Khoo, for that. There we go. Do you want to go to the next one? There you go.
Thank you, Karen. Good evening, distinguished guests, friends and colleagues, ladies and gentlemen. I would firstly like to thank the organizing committee for this kind invitation. I have had a long time working in this very great hospital, and it is good to follow the last two presentations because I don't have to show any more photos. What I would like to do tonight is to delve into my memory bank and present to you my story of the Royal Women's Hospital as I remember it. I look at the audience and I can see there are some of you who form part of this story that I'm about to give you. And I also realize that you also own a memory bank. So if there are errors in omission and commission, I apologize from the very beginning. I have had a long association with the women's. As a final year medical student in 1965 and progressed on to be Director of Gynaecology. In the latter years, I held the position of both the director in the hospital as well as the head of an academic department. I first would like to tell all of you that the first 50 years of this hospital has been recorded by Dr. Ross Patrick in his book published in 1988, entitled The Royal Women's Hospital, The First 50 Years. It is really worth reading. My version is not formal, it's not official. It is just coming up from my memory bank, so I apologize if I do omit anyone or I give you a wrong position. And I'm going to test you out tonight to see how many errors I've made as I make this presentation. I think it is important to look back because history gives us lessons in what to do in the future. And as I look at what I remembered, there are certain unbelievable anecdotes. And I'm going to show you just the three of them. Amy, how do I change the slide?
We're just going to click. Here we go.
Okay. So I'm going to go on to what I have experienced as a young registrar working at the Women's Hospital. Those were the days when the consultants talked to us very frequently, and there were three anecdotes that really stood out in my memory. I do not think they would ever happen again. They represent the idiosyncratic behavior of some of the older consultants. Let me start with the first anecdote. There was this consultant who had problems with sleeping at night. He would wake up at about 3 o'clock in the morning to have a cup of tea. And while he was doing that, he wanted to talk to someone. And who better to talk to than to ring up the registrar on duty for a report on activity in the labor ward. This would happen every time he is on the roster. And I happened to be on the roster with him many times. So imagine my emotional reaction, especially when I was trying to catch up on sleep during a busy night. I won't tell you his name, but some of the older consultants would know him. So this is a true story. The second anecdote. There was this consultant who had a wooden prosthetic leg. It is a consequence of war. When called to advise on what to do with the delay in the second stage at birth, he would ask for Barnes forceps, which he would apply very deftly on the baby's head. And then, would you believe it? He would walk out of the room without saying a word. In my first encounter as a young registrar, I didn't know what to do until the kind midwife present in the room said, "Go and pull on that forceps and get the baby out. He does that all the time. He has trouble in pulling on his prosthetic leg." I think you know who he is. Now to the third anecdote. This was a consultant who was known to come in and do all the cesarean sections himself, and that made registrars very angry. I think Stephen can contest to that. And at one of his early morning ward rounds, he was told by the registrar, that happens to be me, that a swab was missing. An X-ray has shown that it was located in the patient's abdomen. What did he do? He came to the patient by her bedside and said, Mrs. Smith, how inconsiderate are you? You had a swab inside your abdomen. Now I had to go in and operate on you again. To this, the frightened patient replied, I'm so sorry, doctor. Imagine how the patient would read and react to this information today. Very differently. With all this humor now, I will take you through more seriously the history of the hospital. And I'm glad it wasn't given in a temporal fashion by Stephen or Alanna, so I would like to take you through the milestones. In 1929, the decision was made to build a new maternity hospital. It was to replace the small and crowded and only maternity hospital at that time. I think the oldies might remember it as the Lady Bowen Hospital in Wickham Terrace. I don't, so I'm not that oldie. The increase in the population in Brisbane had demanded an increase in hospital beds in Brisbane. So on January the 15th, 1934, this is an important time, it was announced that land had been acquired adjacent to the Brisbane Hospital at Hurston. The site faced Bowen Bridge Road. It took 4 years. It took 4 years, and at a cost of a princely sum of £201,779. And that, I think, is factual to the last pound. I don't know how it was costed. And I think this kind of money will probably not get you a house today. And on 13th of March, 1938, there was the birth of this hospital. The building was completed and was then declared open by the then Minister of Health, Mr. Edward Hanlon, known fondly as Ned. I don't know the origin of that. I thought Ned was a horse. His bronze statue, I think, has been shown by Stephen to stand at the entrance to this hospital. And it greets all of those who visited the hospital or worked there until the demolition of the hospital, and I think it now stands somewhere else. Stephen might be able to tell you, but I haven't. I haven't seen that statue ever since. In 1967, it acquired the name Royal because Queen Elizabeth II thought it was important that the women's hospital should be named with royal assent. And so it changed to the Royal Women's Hospital. And in later years, it changed again to become the Royal Brisbane and Women's Hospital. As we all know, it is difficult to stop the force of progress. With progress came destruction and change. So in 1998, I think I got it in 1998, Stephen got it in 1999. We split it. 1998 and a half, the original building facing Bowen Bridge Road was torn down to make way for a massive new complex. It was designed to accommodate both the Royal Brisbane and the Royal Women's Hospital, and as would be expected, the physical closeness inevitably led to functional merger. As they call it in business terms, the two hospitals became one and serving as the major tertiary hospital for Queensland. The women's was given 3 floors in that Hanlon building, and that was only after a lot of negotiation. Level ground was for outpatient services, level 5 for the hot areas of labour ward and operating theatres, and level 6 for inpatient wards, both for maternity and gynaecology. I believe this allocation of space allowed an efficient delivery of services that we enjoyed and Inevitably, we lost some in the intervening years. In 2000, it was pleasing to see that research was finally recognized. And that's very close to my heart with the opening of the teaching and research area. We managed to persuade the government of the day to assign 1,000 square meters of space in level 6. This was a great win for those of us who were interested in research as well as clinical medicine. And as a result, the first 3 research units were born. As you can see in the slide, the occupants were Perinatal Research Centre, led by Paul Colditz, the Queensland Centre for Gynaecological Cancer, led by Alex Crandon and later by Jim Nicklin, and the Betty Byrne Henderson Women's Health Research Centre, led by me. Born out of this was this law study. This was the baby that I have been trying to nurture for the last 18 years. We ran a longitudinal study on aging in women, and in short, LAW. So there's nothing legal about it. It just happened to be the acronyms. The mission that we have in mind when we started it in the year 2000 was that we want a holistic evaluation of a cohort of women. They are older women, aged between 40 to 80, recruited from the population. They are not hospital patients. And involved the assessment of many body functions. We want it to be a comprehensive assessment of what the woman is like at the beginning. So we measured the heart by echocardiography, and I think Greg Scalia was the one who did all the hard work. We measured cognition, everyday memory. The endocrine system was tested with 24 analytes. Bone health by DEXA. We also measured the fat and lean mass composition, which the patients never like because we tell them you got a lot of fat tissue. We measured postural stability, nutrition, target genes, dentition, and arterial compliance. So it was a fairly intensive assessment of what the woman is biologically. The primary objective was to determine what effects aging had on the various body functions, how changes over time impact on the development of serious health outcomes, and what factors were predictive of ill health. We are, I don't know whether I should say sadly or happily, we have spent over $3.5 million. They were received from grants, and I acknowledge with pride the main sponsors were the Royal Women's Hospital Foundation, supported by the Asian Chinese community, together with National Health and Medical Research Council. The study has published 45 papers, supported 12 postgraduate students, and received high commendation from the World Health Organization review team that we invited them. I am sure at this point in time, you are thinking the burning question. Is there an elixir for youthful existence? Everyone wants to know that. What do you think my answer would be? I have to say factually, on results from our studies, there appears to be no magic bullet to slow or to stop the process of aging. However, we know that age itself was the strongest factor to deterioration of body function. So how do we change our age, I think will be the next question. We are able to confirm, and I think it's good to confirm, even though it's not a new finding, to confirm that obesity, hypertension, diabetes, all these comorbidities, and high cholesterol level, especially in combination as the metabolic syndrome, were very significantly associated with serious health outcomes. Further, we want to know what can help us avoid these outcomes. The only thing I can say statistically is that it is physical exercise. We have found that the outstanding lifestyle factor for a better maintenance of body function was physical activity. If you exercise 5 hours a week, that's not a tall order. You will reduce your likelihood of developing arteriosclerotic diseases by 50%. So I think it's time that you all stand up and jiggle around, because that will help you. Now, with all that, I will now get into the serious part of this presentation. I will deal with 2 parts. The first part will be to talk about the medical personalities that I have encountered, that I have befriended, that I have known in the period I was there, and that was 36 years, 1970 to 2006. And in the second part, I will talk about the achievements of the hospital, for which we should be very proud of, the innovations and the developments which I believe have defined the hospital today. So who are the medical personalities? The hospital was fortunate to be staffed by dedicated and loyal doctors. They range from registrars, visiting consultants, staff specialists, university staff, and medical administrators. I don't have the time to talk about nursing staff, so I'm not saying nursing staff do not contribute. They do, but I'm just going to pay attention to these medical people. And as we all know, with any large organizations, the administrators will know there were differences of ideas, opinions, interests, personalities, and they arose from time to time. But I believe the diversity is really a strength as well as a source of conflict. And overall, I believe strongly that with this kind of discussion, a common purpose was developed, and this common purpose has made the hospital prosper from the hard work put in by the staff. So let's start with the first group of medical personalities. I think you will know most of them. And Wilson, I suppose, would be known to Brian Hill very well. Anybody else have personal experience with Ken Wilson? Oh, well, great. It shows your age, because he was the first medical superintendent. And as you can see there, Ken Wilson was succeeded by Brian Hill, and then David Cooper, then John Campbell, and Ivor Thomas. We had only one executive medical director, and that was Ian Jones, and who was a very strong advocate for the medical staff. The obstetric directors, with new management structure, started with Don Cave, who came from South Australia, Thierry Somville from Germany, and then Rebecca Kimball. And the gynecology directors, I started it, and then pass it down to David Bartz. And I think the most current position is a combined position, which is occupied by Lee Manuzzo. I'll tell you something about these interesting medical superintendents. Ken Wilson and Brian Hill ran the service very efficiently, and they ran this service despite heavy patient load. You have seen it, over 10,000 deliveries. And they could only make do with 4 registrars. There was no overtime. I don't know what they did. Probably all delivered by midwives. But they did it. And now I don't know how many registrars are on the service. I think Stephen hasn't given us that number. He just tabulated it just very, very diplomatically. 19, okay. 19, 4,000 deliveries. 10,000 deliveries, 4 registrars. How does that match? David Cooper. David Cooper was a very approachable medical superintendent. He seldom raised his voice, and he was always receptive to changes. He gave registrars more responsibility in patient care and at the same time stood by them when problems arose. And I think that is good to have that. And as a registrar then, I benefited from this type of mentorship. When John Campbell and Ivor Thomas took over, there was a change in patient demands and expectations, and really that put in a huge load on their time. They had to manage patient complaints. I remember how well John used to roam the hospital in the early morning. He greeted everyone, from wards people to patients to staff, like they were long-lost friends. This attitude, I believe, has really changed the patients from being wanting to complain about the hospital to being very friendly with the hospital. I think we should do it more often now, Karen. John was really a wonderfully personable man. I remember Ivor as a fair and very intelligent manager. He never had a bad word for anyone, and he was always ready to help any registrar in trouble. He was diligent as an administrator and supported staff in patient care, and to the extent that he would fill in on any registrar who couldn't turn up for duty. That is a very bad precedent. Now, the service directors, as I mentioned, was Ian Jones as the executive director. He was a great advocate, and we actually valued his directorship. I'm in trouble. The buttons are so close to each other. Is that right? You've got to have very nimble fingers. Now let's talk about the visiting consultants. I have arbitrarily divided them into two generations. The first generation, as you can see there, were names that you will probably not recognize. Yes or no? Who has personal experience with Jeffrey Shedden Adam? Wow! Right. I have. In my Viva. That was the only time I encountered him. Robin Charlton, Charlie Marks, Keith Coburn, I think we've had mentioned, Roger Salter, Murray Elliott, Sid Page. They all went over to PA when gynecology took over, except for Brian Hill. He didn't go with them. Is that right? Lionel Sapsford, Dick Drake, Jim Hemsley. And the second generation, Brian Hill, Brian Smith, Eva Popper. Good to see Eva tonight. David Cooper, Dan O'Connor, Peter Foote, Alan Lee, Barton Clark, who's here tonight, Adrian Guest, Ken Fry, Roy Hemsley, Ron Adam, Anush, Krisma Narrowly. These staff members, over the years, as I remember it, provided a lot of good work for the hospital. They contributed greatly to how the hospital is today. Let's look at some of them. Brian Hill, Brian Smith, Ron Adam. I remember well Brian Hill, great advocate of vaginal surgery. He believes anything can be taken out vaginally, regardless. Now, that's an overstatement. But he certainly is a great proponent, and I think we value his teaching of registrars throughout the generations, and I hope that this technique does not wither with age. I feel very sad to see that vaginal surgery is no longer promoted as an important part of surgery. Most of it is done by laparoscopy. Eva Popper. Eva Popper, I think her main contribution, apart from being the first female consultant, is the fact that she became very interested in rhesus isoimmunization, performed the first fetal transfusion. Am I right or not? Or is it Ken Wilson? I thought it was Eva Popper who did the first transfusion. Where's Eva? You were the first one? Okay. I stand corrected. Okay. David Cooper introduced ultrasound imaging to the hospital, and even though he was self-taught, his reports were always reliable, responsible, and accurate. Most importantly, he provided us with even a comment on how to manage the case, and that is because he was a sound clinician as well. Infertility was started because of interest by John Hennessy, Alan Lee, and continued by Kevin Forbes and Anushya Dani. And even though the hospital would not allow them to bring in IVF as a form of treatment, they were able to treat a lot of patients without the need for IVF. Brian Hill, Dan O'Connor, Adrian Guest, I believe were the leaders in the introduction of colposcopy. And I think eventually it's called the dysplasia clinic, because I think Brian Hill was the one who started the smear clinic before my time, and then it became the colposcopy dysplasia clinic. Cervical cytology service was taken up by Peter Foote, and I think that was eventually given to the cytopathologist because nobody else wanted to look down the microscope. Further contributions, menopause clinic. With my interest in the menopausal health, I persuaded Sheila O'Neill and myself to run a tertiary level menopause clinic. I think the nurses can remember that. Unfortunately, that has now not been continued because nobody else wants to do it. I encouraged Rebecca Kimball to take on adolescent gynecology clinic, and it's good to see that it has prospered tremendously with that early start. Narelyn Agenda came to me asking for what to do with myself in the outpatient clinic, and I said, Narely, look down the vulva. So she has started the vulval diseases clinic, which I think is still going on well. Advanced endoscopic surgery, I believe, is going to be the main surgical equipment. And it is good to see that, as you can see, David Bartz and Akram Khalil has responded to this task of developing advanced endoscopic surgery, and they did it wisely in collaboration with surgeons and urologists. This was a much needed service in the management of extensive endometriosis. Eric Mackay, I see he's here tonight. He and Keith Coburn were twins. They were self-taught surgeons, one teaching the other and vice versa. Because I was the registrar, I knew all about it. They were very skillful in dealing with difficult pelvic conditions. They were the first to introduce radical cancer surgery to the hospital. They recognized the importance of multimodality approach and the importance of well-trained surgeons in gynecological oncology. And I think Jim Nicklin is one of the beneficiaries of that international training. And there were 4 of them who had international training who came back to serve the hospital: Maurice Webb, Alex Crandon, Bruce Ward, Jim Nicklin. The staff specialists. The staff specialists were not as glamorous, but they did a great job for the hospital. As the visiting staff became busier in private practice in the 1980s and 1990s and less available to the hospital, who else is left to do the job? It became the staff specialists, and as you can see in that list there, they have provided good service, they have provided supervision of the registrars day to day, hour by hour, and also response to emergencies. And as a Director of Gynaecology, I value these staff specialists because of that service. University consultants. It didn't come about until 1963, 64, okay. Before that, it was only a token professor, part-time, Geoffrey Shedden-Adam. The influence of academia began with the appointment of the first full-time professor in the University of Queensland, and that was Eric Mackay, 1964, who came from a very distinguished career in Melbourne, and it was not before long he assembled an academic team. As you can see there, John Campbell and Dan O'Connor initially were appointed as part-time senior staff. Then John Biggs came from Melbourne, and Jeff Logan from the United States. Anyone remember Jeff Logan? Only Brian. I myself don't remember him. And later on, I came on the scene. Ian Jones from New Zealand. He's now Australian, I think. Bruce Ward, Kevin Forbes from Adelaide, and Mark Arian from England. Eric contributed substantially to the hospital, and I think we pay homage to that because I have had many long years with him. He has introduced an interest in translational research, formal undergraduate curriculum, and radical surgery for cancer. He continued as university head for 25 long years until 1988. That was a long stint. He did it very well. And only then that I succeeded him. And I became only the second head of obstetrics and gynecology located in this hospital. Karen? And I continued for another long stint, another 24 years. Now, what are the achievements of this hospital? Throughout this long history, the hospital has provided good service to women. Pregnancy care, management of female reproductive diseases. It served as the only tertiary referral service for many years until the Mater Mothers was commissioned. There were many developments in gynecological practice. However, I have only time to mention 4. The first one is endoscopic surgery. The original laparoscope, I think I stand to be corrected, was first introduced to the hospital by Eric Mackay. It was a big, rigid scope, and would you believe it? I was his senior lecturer at that time, and he said, go and put it into the abdomen. So imagine how I was so fearful using a sharp instrument to put into the abdomen. Fortunately, that was the beginning of the use of the laparoscope. And as you know now, it is the technique that has become an essential equipment for surgery. And it's extended into not only diagnosis, but definition and treatment of pelvic diseases. And I think the hospital administrators initially didn't want it because it was the disposables are too costly. However, they were eventually persuaded because there was more rapid post-operative recovery and then reduced hospital stay. And eventually the economists did a cost-effective analysis and found that it is the way to go. So the hospital embraced this form of surgery and to its credit encouraged staff to improve and extend the range of advanced techniques. And this was led by David Bartz and Akram Khalil. The second development was introduction of ultrasound imaging. And I think we all know that this innovation introduces a new dimension to medical practice. And it's all thanks to Ian Donnell in the 1950s, who first developed the grayscale. Ultrasound imaging now has been used in nearly all areas of clinical medicine, to the extent that we now berate our registrars for not wanting to do a vaginal examination. They think ultrasound is going to tell us everything, which is not correct. However, along with other Australian hospitals, the hospital invested heavily, buying many types of progressive equipment, and I think that is important, firstly, to improve technique and to give us a better picture. The technology has now been found a very useful place in gynecological practice. In the early 2000s, the introduction of the transvaginal probe, I believe, is a very important mark to allow gynecological investigation by ultrasound. And there was no longer any more need to keep patients in hospital just for observation. The early pregnancy complication, the painful pelvis, we do not need to say we'll keep her for 24, 48 hours and see what happens. We use real-time transvaginal ultrasound, and that will allow us to say the patient goes home or not. The third one has been mentioned by Stephen Cook, and this is the introduction of Mirena. This is an interesting innovation. It is an intrauterine system. I've been told never call it a device because the device is confused with this IUD problem. It is not an IUD. It is an intrauterine system which works by a constant drug release mechanism within the uterine cavity. And what happens is that the influence of a progestational agent like levonorgestrel will work on the endometrium, make it a contraceptive technique, and reducing menstrual bleeding. I can make some humble claim to the introduction of Mirena to Australia. It was at a scientific meeting in Finland in 1980 that this system was then discussed. I was quite interested by the potential of it, and I persuaded the sharing company to bring it into Australia. And as they say, the rest is history. The Mirena has flourished in gynecological practice. Because of my interest, the hospital was the first to accept the Mirena for public patients. At first, it was for long-term contraception, and it was then extended to control of heavy uterine bleeding. And within 5 years of this introduction into the women's, we found tubal sterilization has nearly disappeared from OT lists. And the rate of hysterectomy, as Stephen Cook has said, has declined markedly. Is this a good or bad thing? From the registrar's point of view, it's not a good thing. But from the administrator's point of view, it is fantastic. It was a good outcome for the hospital to manage an ever-increasing shortage of beds. Now I come to the fourth development. This development was introduced by the college. The college saw it fit that there should be an elite group of people trained only in a restricted area, but in great depth. So it is a subspecialization. We in the hospital in gynecology have accepted two subspecialties, oncology and urogynecology. Gynecological oncology was initially led by Maurice Webb, Alex Grandin, and then Jim Nicklin. I believe strongly that it grew rapidly because of the expertise of these people and has become one of the largest and most productive units in Australia. So Jim Nicklin, you should take pride in that. Urogynecology was more restrained, unfortunately, because of an overlap with general gynecology. And as the Director of Gynaecology, I used to have to arbitrate between general gynecologists and urogynecologists wanting to do vaginal surgery for incontinence. I'm glad I'm no longer in the position. And in urogynecology, one of the innovations that came about was the introduction of urodynamic studies. And I remember very well, I have frequent visits from Barton Clark, who is here tonight. He badgered me. He wanted the urodynamic equipment. And I said, we don't have the money. We don't have the money. We don't have the money, until he finally got it sponsored by a drug company. And so it thrived. So he should be the one to be given the honor of introducing urodynamic study for a better understanding of urinary incontinence, which are measurable as well as better measured and defined. So I now come to the last bit, and the last bit is about the future. Does the Royal Women's have a future? Naturally. I'm confident that the foundation built in that first 80 years will stand the hospital in great stead. There is a tradition of excellent service to the community. And I would commend all the staff who have worked in those 36 years with me, because they have brought the hospital to this present state. So the challenge that is facing the hospital today is how to deal with the culture that have evolved over the years, how to retain loyalty, cooperation, collegiality, willingness to share, and working as a cohesive unit. The answer naturally lies in the staff at all levels and the environment which allows them to thrive and succeed. So in conclusion, friends, colleagues, ladies and gentlemen, I wish the hospital a great future. And I think with the sound guidance of present leaders like Karen last and Lee Manuzzo, I'm confident that they will continue the traditions that we oldies have been working so hard for the last 80 years. So thank you very much for listening.
Thank you. Thank you very much, Prof. Khoo. Thanks for your entertaining thing. That was very, very wonderful. Thank you. Thank you very much, Prof. Khoo, for that entertaining presentation, also the history and all of the changes that have occurred over the time at the Royal Brisbane and Women's Hospital. I actually think that we do have, it's very good from all of the presentations tonight to have heard all about the challenges and the wonderful opportunities that we have at our hospital. We do have some, obviously, changes that are occurring in training of registrars and also of midwifery students, and challenges to meet the requirements that they need, as well as changes that are occurring with increasing complexity of patients that we care for. I'm pleased to say we delivered a lady who's had a triple lung transplant the other day. She's had a heart-lung transplant and her baby's doing very well in the nursery. I think it weighs about 2,600 grams now. She was born at about 30 weeks. But they're the type of patients that we look after that are doing well. We've also got the complexities of increasing gynaecological surgery, and we're now doing robotic surgery for some of our gynaecological oncology patients as well too, as well as our ongoing advanced laparoscopic unit and our endoscopic training and our paediatric adolescent gynae unit. We also now have obstetric medicine at the hospital, which is great, looking after those complex patients, because we now know from the statistics that more than 50% of patients that die in pregnancy die because of medical conditions. So I think the staff at the hospital have got wonderful futures ahead of them, and so do the registrars and the trainees, and I think that the consultant staff are really working wonderful to approach all the challenges and the opportunities that we have in the future. So I think it's nice to have heard about the past and to build on that and have the next 80 years a fantastic future. So we won't all be around to present that in the future, but I think that some of us, or not some of us, a lot of us will probably, there might be some photos of us up there as well too in the future. So I just would like to finish by thanking all of our speakers, Alanna, Geary, Soo Keat Khoo and Stephen Cook, for actually their entertaining and interesting presentations tonight. I've just got a quick thing to say. It's great to hear all of these stories and about the Women's Hospital. It appears evident that throughout time, despite all the changes and developments in women's and neonatal health, two things seem constant at the Women's Hospital: a sense of teamwork by all of the staff at the Women's who work together to achieve the best possible outcomes and for those that we care for, and a total focus on the best outcomes for the patients that we care for and their wellbeing overall. These two constants will ensure that the Women's Hospital at the Royal Brisbane and Women's Hospital will continue to provide great and compassionate care well into the future. I'd also like to thank our platinum sponsors tonight, QBank, for all your support for the alumni. I'd also like to mention that membership of the Royal Alumni enables past and present staff of the Royal Brisbane to stay in touch and connect with their colleagues on a professional, academic and social basis, and it allows members to be kept updated on current developments that are going on at the hospital. Don't forget to take your program home, because there's a date claimer on the back of it about a hospital tour, and also about sending information about being mentors to our current registrars, residents and medical students. And try and connect with as many staff as you know, and try and encourage them to become members of the alumni, because it actually does help you connect with people, I think, socially as well. So I think that concludes our formalities for the evening. On behalf of the Royal Alumni, I'd like to thank you all for joining us tonight and for being here and for enjoying this entertaining evening about the history of the Royal Women's Hospital. I'll hope you join us again in future events regarding the history of the Royal Brisbane, and I hope you've enjoyed the evening and that you have a good night tonight. Thank you.
Ladies and gentlemen, one thing as Chair of the Alumni, can I thank the three speakers for their wonderful presentations, and to thank Karen very much for being a wonderful MC. Thank you. Thanks. Thanks.
Drive safely. Press the button. Press the button. Press the button.
That's it.
Oh, there you go. 4 September. 4 September. Put that date in your diaries. That's all right, no problem.
Thank you, sweetheart. Cheers, it's great.